So that was a great talk, Dr. Lane. And you really answered a lot of questions that our listeners had today and the viewers had. So I would first like to thank Dr. Dekleva and the organizers of this wonderful day event, and all the speakers that have given their talks already and the ones that are lined up for the rest of the day. So as mentioned earlier by Dr. Dekleva, I'm a physician at UT Southwestern. I specialize in physical medicine rehab and brain injury medicine. And I treat patients with brain injury, TBI, concussion, complicated concussion, post-concussion syndrome. And lately I've also been involved in treatment of the long COVID patient population. And why I mentioned that is during this talk, I think I'm going to lay out some of the principles that we use to treat some of these complicated symptoms or syndromes, which are a constellation of symptoms, and how that can be used to treat patients with Havana syndrome. So just a quick background. We already know by now, Havana syndrome is a constellation of symptoms, right, which started in Havana. That's why the name. And this slide here just lists some of the different acute and chronic symptoms. The ones listed here are the common ones. And I'm saying that again and again is because some of the other conditions I'm going to talk about also have very similar symptoms that we see. So the acute symptoms, as we know, could be some headache, loud sounds, which has directional component, memory issues, vision issues, some of nausea, and a lot of balance issues, while chronic symptoms can all involve headaches, impaired concentration, memory loss, cognitive symptoms, sleep issues, mood and psychological issues, including anxiety, depression, and some of the vestibular or balance related issues. So now, so far, whatever the studies that were presented or that have come out, the ones especially that started in JAMA, and then some of the most recent reports and investigations that came out, the last one being the one from the National Academy of Science, the Relman report that came out towards the end of 2020. Most of these studies were not able to clearly identify the exact etiology or the exact reason of these symptoms. They did postulate a lot of mechanisms, and we do, it's been discussed already today, we know that there are certain mechanisms that could play a role, like ultrasound waves, or there was a theory for like microwave waves, whether it was a concussion, where it was like a concussion, as earlier mentioned, like an immaculate concussion without a physical impact, or some of the other mechanisms that is disturbance of the brain, which causes disturbance in the vestibular system. So all these mechanisms postulate some mechanisms, but do not clearly pinpoint. So what that tells us is we know a little bit, but we do not know the exact reason. So that itself tells us that the treatment of these disorders is going to be focused mainly at the symptom treatment, and also using our principles that we know from some of the other disorders that we commonly see. And the list that I've put here is some of the common syndromes or treatment we all see. Some of them were already discussed by my colleagues earlier. Dr. Monroe and Lucrece mentioned about concussion, post-concussion syndrome. Dr. Lane mentioned about traumatic brain injuries, similar, mild versus severe. Dr. Bay mentioned about vestibular migraines. And Dr. Kutz gave some idea about some of the ENT or ear-related pathology that can contribute to these symptoms. And we're also going to see later today about PPPD, which has been mentioned multiple times during today. And then the functional neurological disorder. Some reports that I already read about Havana syndrome earlier. The first one that initially came out, the investigation that was done in Cuba, they also mentioned a possible functional neurological disorder type of etiology. And so I included that here. And for purpose of this talk, I'm going to mainly focus on the rehabilitation techniques and principles that we use in these disorders. The overall treatment of these conditions include a lot of different specialists, as it has been mentioned, and it's an integrated multidisciplinary approach. But I will mainly focus on the rehab techniques. So talking about the first one, post-concussion syndrome. These are the diagnostic criteria for post-concussion syndrome. And if you see, the most of the symptoms that are listed here are pretty much almost the same as that were listed in one of my first slides in Havana Syndrome. So we have headache, we have dizziness, we have fatigue, we have irritability, sleep difficulty, and then the cognitive symptoms. That's difficulty concentrating, focusing, and impairment in memory. Same were really mentioned in the DSM-4 criteria as well as the ICD-10. So we see there is significant overlap with the symptoms from Havana Syndrome and post-concussion syndrome. The treatment, the symptoms from post-concussion syndrome mainly are divided in these 4 major symptom clusters. And we also see very similar symptom clusters in patients with Havana syndrome. So the number 1 symptom here is the cognitive symptoms, which includes fogginess, difficulty concentration, memory deficits, cognitive fatigue. The somatic or the physical symptoms includes headache, dizziness, balance issues, light or sound sensitivity. The psychological or mood disruption domain includes irritability, feeling sad or depressed, anxious, and then the sleep dysregulation can manifest as difficulty sleeping, difficulty falling asleep, or difficulty maintaining your sleep, or fragmented sleep. So the treatment dilemma. I think it was mentioned earlier that a lot of the complex syndromes, though we are in the 2022 right now, and we have a lot of advanced medical technologies and blood markers and techniques and even newer medications, it's not always easy to treat these conditions. And why is that? So we know that once a lot of times, sometimes these patients end up in in a chronic phase. It's not always easy to completely get rid of their symptoms because the symptoms tend to be a little more resistant than they were in the beginning. Plus, there are a lot of other confounding factors. There's a lot of psychosocial overlay. There's impact from their mood, impact from sleep. And unless you really address all these symptoms together, it's not very easy to just focus and treat these 1 or 2 symptoms. There's also, if you specifically talk about concussion, there's a lot that comes surrounding a concussion. So the factors that were around the injury, whether it was a war-related injury or a blast injury, as you see in the veterans, or it may be a car accident, as you see in a civilian, or even a sports-related. It was mentioned earlier that a lot of times the sports-related concussion are the cleanest concussions that we actually can treat because we know that there is lack of these other mechanisms that could impact some of the other injuries. So again, even though we know and we have been treating concussions all so many years, it's not a very easy treatment. Okay, so and now we're going to treatment. So before I go into the individual details of the rehabilitation techniques, being a rehab physician, I really want to stress the importance of some form of aerobic activity and graded exercise. So, and again, we're going to look initially with some of the syndromes we know, right? So starting an aerobic exercise programs sooner than later is actually beneficial. So studies have been done that studied patient sports-related concussions, which had rest recommended and which had some kind of a symptom-tolerated aerobic activity recommended. And it was seen that patients who were actually recommended aerobic activity sooner got better sooner. They had faster recovery, they returned to sport, they returned to their work or school sooner than the other. Sub-threshold aerobic exercise serves as a non-pharmacological medicine. And it also helps you to evaluate your concussion and also helps speed the recovery from the post-concussion syndrome. We also know that moderate intensity exercise improves strength. It improves endurance. It improves mood. it's helpful for brain health as well as your heart, like your cardiac overall aerobic conditioning of the body. And we know that graded symptom limited exercises as tolerated have been beneficial in some of the chronic fatigue syndromes. I mean, chronic fatigue syndromes, as we see in myalgic encephalitis, chronic fatigue syndromes that we sometimes see lately with long hauler COVID. So we know from previous experience that graded symptom limited exercises is actually very beneficial. Similarly, in patients with functional neurological disorder or PPPD, as long as you think it's safe, that means balance is not an issue, some form of aerobic exercise has shown to be benefit. When there is a concern of balance, starting with something that is safe, like a recumbent bike, I would say is a good start, so that you can get these people onto some kind of a gradual program. So now let's talk about some of the specific domains of dysfunction that we commonly see, starting with some of the cognitive symptoms. So we know that the cognitive symptoms range from difficulty concentration, difficulty focusing, short-term memory issues, processing speed, feeling as if I'm not as sharp as I used to be before, not coming up with words that you really want to say, so word finding difficulty. And most times some of these are subjective. You heard Dr. Lakrit saying that there could be a discrepancy between objective testing and what the patient or subjectively mentions. So sometimes we do not find an objective finding, and a lot of times it's still impacting their day-to-day life. But at times we do find actual objective cognitive evidence, which is usually characterized into a mild cognitive dysfunction. So what can we do for all this? Obviously, you also treat the underlying other comorbidities that sometimes very commonly affect cognition. But once that is done, cognitive rehab or cognitive therapy is the mainstay of treatment. So the four most common treatment approaches that are commonly used in cognitive rehab or training are listed here. One is direct attention training, which includes mainly activities focusing on attention, and that could be sustained attention, selective attention, working memory, rapidly shifting your attention from one to the other, and it's combined with some kind of strategy. So how to help yourself in your day-to-day activities, what should you do in certain situations. The next common thing is metacognitive strategy training. We know metacognitive strategy training from learning disability, especially in kids. We know metacognitive strategy from PTSD type of treatment, but it can be used in any form of cognitive dysfunction. What it includes really is self-monitoring, self-regulation, knowing what's going on and how to modify or influence the outcome. And it uses strategies to facilitate self-regulation and states in the states of mind, academic tasks, and study skills. The third one is usually using some form of a assistive technology or something to help your cognition with cognitive aids. And then the fourth main domain is the psychoeducational support groups, because a lot of these conditions usually have psychosocial ongoing issues. So you have to provide education, you have to facilitate symptom monitoring, and most important is goal setting. So another term that is very commonly used in practice is cognitive remediation. So a lot of times when we see these patients, we specifically make the referrals to cognitive therapist. It could be some cognitive sleep language pathologist. Sometimes it could be a neuropsychologist or a psychologist, and they work on cognitive remediation. So cognitive remediation is usually very focused. It's goal mediated, and it's a time limited treatment. The main goal is how you set appropriate goals and how you achieve those goals. It's all about optimizing your function and getting back to your day-to-day activities as much as possible. It does incorporate some psychotherapy, and it incorporates some of the other prior domains I mentioned earlier. So attention enhancing exercises, which includes both visual as well as auditory skills, some tasks to improve your attention and processing function, because that's also important for your memory. And then it also works on your capacity for attention, your working memory, short-term memory, and overall trying to improve your overall mental capacity. So what are the other treatment options? So you did the cognitive therapy. As I mentioned earlier, there's a lot of other things that have to be considered and evaluated while you are treating patients with cognitive dysfunction. Some of the most important before you even jump into is healthy lifestyle choices. And that is aerobic activities, managing your sleep. Sleep has a significant impact on cognition. A simple analogy I tell all my patients is really look at your brain as a real estate, or look at as has limited finite resources. Okay, a lot of all these other things, including your symptoms, your day-to-day activities, are occupying it. Okay, if you are not able to actually get rest, and if you get occupied by one or the other symptoms, how are you going to focus the same amount of resources to help your cognitive symptoms? So, and rest or sleep is when you actually give your brain some time to recuperate. That's when a lot of your memories are made, or basically they're ingrained, not made, I should say, they're ingrained or consolidated. And it's also the time that when your brain is trying to get rid of some of the toxins that come out. I mean, there's a lot of studies regarding that, which talks about how the system, lymphatic system, gets rid of some of the toxic that comes in brain, and the sleep is really important for that. Aerobic activities I mentioned earlier. Some of the diets. There's many different types of diet which are usually talked about, recommended. Some of the common ones includes the ones I listed here: Mediterranean or DASH diet. What really it includes is avoiding excessive processed foods, eating some heart and brain healthy foods as essential amino acids, and avoiding basically a lot of fatty food that is not great for your heart and brain, using nuts, using fruits, using raw fibers instead of processed foods. Supplements, obviously there's a lot of talk about supplements. There's some studies that showed some benefit. Again, most commonly talked about supplements are omega-3 and acetylcysteine, coenzyme Q. I'm not going to go into details of that. Some of them may help, some do not, but again, a lot of times looking at the risk benefit, sometimes there's no harm in taking these. So it could help at potentially, and then obviously minimizing polypharmacy, optimizing your medications. Unless you are someone is actively looking at that, you cannot expect your cognition to improve. So adaptive and compensatory strategies, these include really adaptive strategies is basically how you adapt your environment, how you reduce your stress, how you reduce your distraction. You can break down complex cognitive tasks so that it's easier for you to perform. You schedule appropriately. That means if you are doing some form of cognitive task, you have rest breaks before or after schedule, especially if you're taking a test or if you are ready to give some form of interview. You need to specifically break it down or set it up according to your day, how it goes. Also, resetting the expectations. Sometimes it's resetting the patient's expectations. Sometimes it's helping some other people's expectations. And then teaching others not to respond. So a lot of times there's a learned helplessness there. The caregiver is really helping, but at the same time, it's really inculcating a learned helplessness. So that is really important to educate. Compensation, as I mentioned earlier, some of the cognitive aids could be list, could be task, it could be assistive technology, smartphones, your alarms, GPS, especially if you are trying to follow directions or difficulty finding directions are really beneficial. The second common symptom domain that is commonly seen and is accompanied by along with the vestibular issues, your vision or ocular symptoms, and more than impairment, which is actually impairment of difficulty with your acuity or your vision, it's actually dysfunction. Again, here the word dysfunction or function is commonly used because here a lot of times we do not see a structural abnormality or there's no a specific field cut as such. But what ends up happening is there's difficulty with accommodation, there's photosensitivity, there's diplopia or double vision, there's eye fatigue, and inability to do your task. And this is very commonly seen in concussion or a lot of these disorders. So some of the common symptoms that patients report is light sensitivity, difficulty reading, blurry vision, double vision, eye strain. And some of the findings that we see are convergence insufficiency, accommodative dysfunction, photosensitivity, sometimes rarely divergence insufficiency, and sometimes strabismus. So what is the mainstay of treatment? Obviously, you need to get your eyes checked, check for any like refractory errors, look for anatomical changes that happen after trauma or any kind of a physical insult. But once that is done, it all ends up being a vision rehab or vision therapy or retraining. Usually it's done by an optometrist or a trained occupational therapist. Here we have trained occupational therapist that does it in our center. And it's the main elements are training for ocular motor performance that includes the speed and precision, eye discipline, and then processing. So processing is really helpful because not all the time your brain is perceiving the same thing that you saw. The picture here is one of the very commonly used exercises, which is called Brock string exercises, which are used for convergence insufficiency. So examples are your pencil push-ups, convergence surprises, there's cards that are available, or the Brock string is the simplest technique you can teach patients. It's readily available, or you can buy it on Amazon, and that's how you train the patients to help with convergence. Eye strain can be helped with patient education, making sure you are checking for, again, prescription. Teaming exercises are, there's cards that are available, which are called heart chart exercises or worksheets, word searches or hidden pictures, which help the eye and the brain to process. Desensitization techniques are used for your sensitivity and photophobia, and then hand-eye coordination. This is very useful and important, especially if there is balance issues, there's dizziness involved, and there's double vision. So this is a safety issue. So hand-eye coordination, which is done by some of the visual exercises, or Dynavision, which is a device, is commonly used. Now going to the third domain of symptoms, which is your dizziness, vertigo, or your the PPPD or type of symptoms. We spoke a little bit about that earlier, but once you look at, you're evaluated, once you are assessed for any peripheral issues, any structural issues that can be responsible, once that is done, the mainstay of treatment ends up being vestibular rehab or vestibular therapy. So vestibular rehab really is a therapy intended to help your vestibular symptoms, right? Mainly it's based on exercise, it's an exercise-based regimen. And it also uses a lot of eye-related exercise and also gait or balance-related exercise. The mainstay of vestibular rehab exercises is your habituation. So habituation is used to treat your dizziness, because a lot of times the dizziness is worsened by self-motion or any kind of visual stimuli. So people who report symptoms or dizziness when they are moving around or watching moving objects, like a TV or patterns, really benefit from habituation. And the goal is to reduce the dizziness through repeated but controlled exposure in specific environments to stimuli. And it usually does provoke dizziness, but that's how you slowly train the brain to minimize the symptoms. Other exercises that are commonly used are your gait stabilization exercises. And these are, again, it improves your eye control, and they are used especially when there's double vision that accompanies your dizziness, and there's difficulty focusing your eyesight. And then the third one is balance training. A lot of these symptoms includes balance issues, feeling unsteady, feeling a fear of walking on uneven surfaces. So balance training is really very, very important. Some of the common techniques that are done, we know the common name, that's the Epley's maneuver, which is shown in this picture here. These are usually done for peripheral vertigo or BPPV, as mentioned initially by Dr. Coots. And some of similar exercises are the Cawthon Cooksey exercises, which includes movement of your shoulders, movements of your neck, practicing in a supine or a stable and then standing position, and then simpler exercises like Brand-Daroff exercises, which can be done at home. They are simpler versions of your Epley's or the canalith repositioning techniques. Additional vestibular therapy exercises includes tracking, convergence exercise like the vision exercises, neck exercises, and core strengthening, because that's really important, especially when balance is concerned, and then some postural training. Okay, now going on from mostly the concussion and the domains to a little bit about functional neurological disorder, sometimes called as FMD, functional movement disorder or motor disorder, especially when it's dominated by physical symptoms, including limb weakness, gait disorder, involuntary abnormal movements, and sometimes it includes sensory or visual symptoms. So a functional neurological disorder is really a disorder of the functioning of your brain. Okay. It's difficult. Most times there is really no anatomical correlate that we can see. And a lot of times extensive work of including imaging is done, and it is either negative or not truly specific for the deficit that we see. Patients can present with a lot of different symptoms, as I mentioned. Sometimes it's accompanied by a type of seizure, which it can be called a pseudo non-epileptic seizure. These events may be triggered. There's a lot of times a triggering event. It could be a trauma, it could be a concussion, it could be a major psychological event in the patient's life. And the symptoms sometimes wax and wane. So that's how you can distinguish sometimes with some of the neurological. Obviously, you do a workup for other neurological disorder. Most of the time it gets done, but it's a lot of times you may have some remissions. So some of the, we use the same domains of therapy that we used earlier, especially the vestibular PT, your occupational therapy, and the cognitive therapy. But there are certain principles that are unique for functional neurological disorder. This article that I mentioned here is a great article which lists all these treatment principles which really help improve your patient outcomes. So the first and foremost, it's really important to build trust. Before you start challenging the patient, before you start pushing the patient, you need to have a trust. You need to develop or project confidence. The clinician who is helping this patient needs to be aware. They need to be educated themselves first before educating the patient. Because if that's not done, a lot of times it's actually lack of expertise on the provider side that makes the patient uncomfortable or basically lacks confidence in the treatment. Then the expectation of improvement, positive reinforcement, talking to them about the prognosis, that most of the time the prognosis is favorable, open and consistent communication, setting your goals, setting your priorities, and having an open communication is very important. Not making it up, giving false hope at the same time, false prognosis is really it hurts the patient's outcomes during such kind of patients. Involving the family and caregiver in the treatment is useful, as they a lot of time needs a lot of support. At the same time, education of the family members is really important. It says limit hands-on treatment because you really facilitate. You facilitate the treatment as a clinician or as a therapist, and you empower the patient to control their treatment themselves and improve. Encouraging weight bearing is really only it comes into play with the severe functional deficits when people, some patients really have difficulty ambulating and all that. So early weight bearing is recommended. Like I mentioned, you foster independence and self-management. It should be goal-directed rather than focusing on their impairment. You should focus on the ability. So rather than focusing on the disability, you need to focus on the ability, and you need to focus on the function. Minimize reinforcement of maladaptive behaviors, avoid the use of excessive adaptive devices or braces or immobilization, because a lot of times it may not be needed, or sometimes it may actually slow down the progress. And recognize and challenging unhelpful thoughts and behavior. So if someone is really talking about a lot of like the bad prognostic and the bad as like they have lost hope in improvement, I think it's very important to focus their attention on the future, not the past. And develop a self-management and a relapse prevention plan is really very important. The common elements of physical therapy or therapy in FND are similar to that of the other disease. Starts with education all the time, acknowledging the symptoms, validating their symptoms, using some of the normal behavioral patterns, at the same time discouraging maladaptive patterns, retraining with diverted attention. Instead of focusing on your symptoms, with attention when the attention is diverted to something else, something that actually is soothing or pleasing to the patient, and then just focus on the improvement is really beneficial. Desensitization techniques, seeing like mirrors and visualization or feedback is, and then the rehabilitation diary is monitoring your symptoms, looking for what makes it worse, what makes it better. Some of the other therapies I mentioned earlier are similar here as well. You can use occupational therapy, especially there's impairment in the day-to-day activities, and that's affecting the patient's life. And a speech language pathologist can help some of the speech related impairment. A lot of times there is stuttering, word finding issues, and all the cognitive complaints we mentioned earlier. And again, psychotherapy and cognitive behavioral therapy has a huge role in this. I really cannot stress enough about the role of counseling that is involved in these patients, along with actual therapies. I'm not going to go into details of that. And so these are some of the references that I spoke about, and I think we have a few minutes for questions, if at all.
Thank you, Dr. Barshikar, for a very informative presentation. Because it's lunch, we only have time for one question. Scott Sonnen asks, considering cognitive remediation or even habituation exercises, are there assistive feedback and biofeedback technologies recommended to tailor to concussion, TBI, or AHI rehabilitation in terms of clustering the presentations?
Absolutely. I mean, they're actually, I mean, we have neuropsychologists here, so there is definitely cognitive behavioral therapy that is helpful. There are certain, I mean, it's like, where do you start, right? Focusing on your symptoms, improving your other symptoms, self-regulating, and then helping your symptoms to improve is beneficial. There's apps that are sometimes useful, but again, I would start with reaching out to a psychologist or a therapist that is really trained in brain injury. And especially CBT and concussion is not new. So I'm sure there's a lot of data available there. I mean, we have therapists here that do it as well.
Thank you. Thank you, Dr. Barshikar, for a wonderful presentation. Thanks to our attendees. We're going to take a lunch break. It's 12:35. We're going to start at 1 p.m. Sharp Central Time with Suzanne Kelly and Dan Hoffman. Thank you.